But today we're going to talk about tuberculosis. And when it comes to infectious diseases, as we're going to see, tuberculosis is actually the most common infectious bacterial disease in humans on this planet. And it's also still one of the major killers as far as bacterial infections go. When it comes to viral infections, probably the most common viral infection in the world is hepatitis B, which is unusual because we do have a vaccine for hepatitis B. But approximately a third of the world's population is infected with hepatitis B, and also a third of the world's population is infected with TB. So we're talking huge numbers of people. But specifically for tuberculosis, it is a lower respiratory tract infection. Of course, we know Mycobacterium is a rod. It's an obligate aerobe, and it does grow very slowly. We talked about gram staining, and Mycobacterium, it does usually look purple when you do a gram stain. And so for our purposes, we refer to Mycobacterium as a gram-positive rod, but technically there's not enough peptidoglycan in the cell wall to meet the criterion to be a gram-positive organism. But it does tend to stain purple with the gram stain. It also resists drying, and it's difficult for many antimicrobial drugs to penetrate. And the reason why for these things is that thick, waxy cell wall, those mycolic acids. So it's harder to gram stain, it's hard for chemicals to penetrate that thick, waxy cell wall. And when it comes to immunity, immunity against Mycobacterium tuberculosis is cell-mediated. So we're talking macrophages and T cells. So remember, we talked about the immune system, how half of it is your humoral immunity, the antibody immunity, and the other half is cell-mediated. Well, when it comes to fighting TB, it's mostly your cell-mediated immune response that is used to defend against tuberculosis. So this is a simplified. Christiane, you have a question?
Yeah, did you say the reason why it does not gram stain is because it's hard for stain to stay on it?
The thick, waxy cell wall.
No, that's why it resists drying and most antimicrobials.
Right.
But why does it not gram stain? But that's
well, often the crystal violet does not stick well, right, to the thick, waxy cell wall, and the alcohol washes it away. Right? Because remember, crystal violet needs to stick to the peptidoglycan, and there's not a lot of peptidoglycan in the Mycobacterium cell wall. There's more than a gram-negative, but less than an actual gram-positive organism. So when it comes to the simplified mode of infection, as we're going to see from a couple of videos we're going to watch, although we mostly talk about Mycobacterium as a respiratory infection, Mycobacterium can actually infect different parts of your body. You can get gastrointestinal TB, you can get TB in your bones and other organs, even TB as a skin infection. So TB can actually infect different parts of your body, but mostly, at least initially, it starts out as a respiratory infection. So you inhale the TB bacteria, right? They're being released as tiny droplets in the air by someone who's infected, and you inhale them. And the TB travel to the alveoli. They're usually phagocytized by macrophages. Sometimes the macrophages will destroy the TB bacteria. Other times the TB survives inside of the macrophages and goes dormant. Remember, TB does require oxygen, so once they're engulfed by a cell, there's a lot less oxygen available. And the dormancy represents a latent infection, But dormancy can exist for your entire life. So you may go through your entire life with dormant TB. And if it's dormant, you are not infectious and you have no symptoms of the disease. So you're basically just fine. But at some point, latent TB can become reactivated. So macrophages and other cells do accumulate around the TB bacteria, surrounding them, creating what's called a tubercle. And then, as we talked about with the immune system, inflammation is an immune response. But when it happens in the lungs, it can cause damage, right, to the lungs. But if you're lucky, your tubercle may heal, and it actually becomes calcified. So you can see these calcified tubercles in a chest x-ray. Now, when it comes to being tested for TB, we will see in the video how that's done, but the idea is that they inject you with some TB antigens and see if you have a reaction. But you cannot do that if you have received the BCG vaccine for tuberculosis. So in many countries, they vaccinate against TB. Not here in the United States, because TB is not a major problem. But in many countries, they do use a BCG vaccine. It's not a great vaccine. Mostly what it does is help to keep children from dying from TB. But if you've been vaccinated, you typically have a positive skin test for TB. So they always will give you a chest x-ray. And what they're looking for is to see, do you have an active infection now? Did you have one before? Do you have calcified tubercles? Are your lungs clear? But since most of you are going into healthcare, you must be tested for TB. If you come from a country where you were vaccinated, you will have to get a chest x-ray. Now, if your lesions do not heal, then they grow, and the TB bacteria multiply, and then you have an active infection, so you're very highly contagious. So you inhale the bacteria. Remember, the portals of entry and exit are related, so you inhale droplets from someone who is infectious. They get into your lungs. If you develop active TB, you will start coughing, which means you're releasing lots of droplets with TB bacteria. So that's how you can spread it to other people. It's possible for your TB to disseminate, to spread throughout your body and cause very, very severe conditions. If you remember the Hunchback of Notre Dame, I did a movie about a hunchback. His hunch was actually spinal tuberculosis, so he had TB infecting his vertebrae. If it were on food, it's possible you could get gastrointestinal tuberculosis. But you need more than just a few droplets on your food. So as you'll see in the video, that usually happens to people who have very active respiratory infection and they swallow a lot of mucus from the lungs, and that's how they get gastrointestinal TB. So dormant TB can be reactivated. So remember, if you're infected with TB but it's gone dormant, your immune system is helping to keep the TB dormant. So if your immune system declines for some reason, then TB can be reactivated. So maybe you just get really, really old and your immune system is no longer functioning that well. Maybe you're undergoing chemotherapy, right, for cancer. That reduces immune function. Maybe you have HIV infection and you progress to AIDS. That will allow dormant TB to reactivate. So there are many possible reasons why your dormant TB can be reactivated. But for most people, if they have dormant TB, it does tend to stay dormant their entire lives. But if for some reason you become immunocompromised, then your TB can reactivate.
Professor?
Uh-huh.
You mean TB cannot be cured permanently?
Yes, it can, but with antibiotics, we're talking about people who do not receive any antibiotic therapy.
Okay.
And then if you have dormant TB, it is very possible that you would have antibodies or that you would have activated T cells that can respond to the skin test. So you may in fact show a positive skin test, and then they would automatically do a chest x-ray, right, to see if your TB is still dormant or if it has become active. So usually a prior infection with TB does produce an immune response, so your skin test will show up positive. And then you have to get a chest x-ray. When it comes to statistics, again, statistics are always changing. Around 10 to 15 million people in the United States are infected with TB. In 2013, there were less than 10,000 cases of active tuberculosis. So the overwhelming majority of people with TB, it is dormant. When it comes to the entire world, as I already mentioned, a third of the world's population is infected with TB. So that's over 2 billion people have TB. And around 1 to 2 million people still die every year from tuberculosis. So that makes TB the #1 infectious bacterial infection that kills people. But death rates have been decreasing. So things have been improving. Why is only using 1 or 2 anti-TB drugs usually not effective? So you guys should be able to answer this. Why is it if you just try to use one antibiotic to treat TB, it's most likely not going to work?
It's probably very resistant.
Right, resistance. We've already learned there's always some resistance present, right, to any given antibiotic. So if you were to use a single antibiotic, yeah, you may kill off the majority of TB bacteria, but not all of them, right, that are in that patient. And those bacteria will multiply, and then you will have a resistant population. So we know that you must use more than one drug to treat TB, because there's always some resistance present. And in fact, this was one of the problems with TB, because when we first discovered antibiotics, we eventually found that streptomycin appeared to work against TB. And so we started treating patients who had TB with streptomycin. And then we just ignored TB. We just kind of looked the other way and sort of forgot about it because we were like, we can use streptomycin, right, to treat TB. And so doctors and scientists just ignored TB for decades. And they didn't realize what was happening. And what was happening is that TB was becoming more and more resistant. And so because doctors and scientists ignored TB, we ended up with strains, multi-drug resistant strains of TB, and there was few or no ways to treat it, with certain cases. So, but that was because doctors and scientists just kind of ignored TB for a long time because they were like, we have antibiotics, you can treat it with streptomycin. And they didn't realize that using just one antibiotic was simply selecting for resistant bacteria. And so we ended up with a much worse problem, right? Because we ignored TB for a long period of time. When it comes to the number of people infected with TB who develop active tuberculosis, the number is relatively low. It does vary somewhat depending upon the source you're looking at, but in general, only about 10% of people infected with TB actually go on to develop active tuberculosis. And the other 90%, approximately, those people, TB goes dormant. And for most of them, it's going to stay dormant their entire lives. So your risk of actually developing active tuberculosis is relatively low. Now, HIV infection and the HIV pandemic did have a dramatic impact on the rates of active TB cases. Because remember, we said a third of the Earth's population was infected with TB, and in approximately 90% of people, it was dormant. But then the HIV pandemic happened. So as HIV began to spread and people began to develop AIDS, if they were infected with dormant TB, the TB would reactivate, right? Because they were immunocompromised by AIDS. In particular, it was the T cells, the helper T cells, right? Destroyed by HIV. And the helper T cells stimulate cytotoxic T cells. And your immunity against tuberculosis is cell-mediated. So HIV, it was destroying that part of the immune system, which kept your dormant TB dormant. So as the HIV pandemic spread, the rates of active TB cases increased, and they increased dramatically from the 1980s, 90s, and into the 2000s. But as treatment for HIV improved, right, we have all those wonderful anti-HIV drugs that led to the decrease of active TB cases. So there was a period of time earlier in the HIV pandemic when the rates of active tuberculosis increased dramatically. But as treatments for HIV improved, then the numbers of active TB cases began to go down. So here we see the consequence of one infectious disease leading to an increase in another infectious disease. Now, why is it important to manage, treat, or even care about diseases in the developing world when they're not problems in developed countries? So beyond the obvious humanitarian reasons as to why we should help, why should we care? If there's some outbreak of some disease in some other part of the world, why should we care about it?
Because of people moving from one country to another, immigration.
Mm-hmm. Right. I mean, is there any country that truly exists in isolation anymore? Do human beings stay in one place anymore? It's like, no, right? People immigrate, they travel, right? We go on vacations, we go to other countries, right? We see new things, meet new people. So, there's a lot of transportation and commerce in between countries. So no country truly exists in isolation anymore. We're a global community. So if there's an outbreak, okay, Clarice, if there's an outbreak in one country, we need to go see what's going on, right, to help. Yeah, so some of us are not able to hear. Hopefully they'll refresh or reboot and come back. But the rest of you can hear me okay, right?
Yes.
Yeah,
Yeah.
good.
Yeah. I know some people this morning also had some problems with the being able to hear me, so nothing I can do about it. So hopefully when they reboot, they'll be able to get back in. But as I was saying, people travel. We got planes and ships, right? International commerce, international business, right? Traveling, immigrating. So if there is a disease outbreak somewhere else, it's not going to stay there. And so that's why we have to care, right? We have to provide assistance, because if we don't, eventually whatever that disease is going to spread, and it will make it over here. So, beyond the obvious humanitarian reasons, we need to help people who are sick. We also need to do it for ourselves. Look at COVID-19. It spread all over the world. It spread very easily and very quickly. And so that's why we need to pay attention. Of course, certain countries are not always that willing to release information, or at least release the information in a timely fashion. But we do have organizations like the Centers for Disease Control here in the US, the World Health Organization, that are constantly monitoring, right, of the world, all these different countries. And so they're trying to pay attention to outbreaks of disease. But as I said, if you have certain countries that are unwilling to release those data, at least to release them early enough, right, to help, and then that creates problems for the rest of the world. So, and of course that did kind of happen with COVID-19, right? So Roxy, are you back? Can you hear? Roxy, can you hear me? Yeah, I'm not sure if everyone can still hear or not, but nope. Oh. So if you ever have a problem and you just can't connect, or you can't, yeah, if you shut down the entire computer and reboot, that usually fixes the problem. So we'll just wait a minute and somebody else. Microphone is denied. That's weird. Yeah, let me just check something here. Yeah, if you guys have any suggestions, feel free to offer them, because her microphone is denied. I'm just checking the settings now for the session, but should all be good. Yeah, if anybody's using Mac, I cannot help you because I don't use Apple products. So I'm a PC person. Well, we do have 2 videos to watch, so I'm going to share my screen to show the videos, because on YouTube, especially with one of them, we had 3 commercial interruptions during the video. So if we watch them on my computer, hopefully that won't be a problem. But also the closed captioning may not be available since I downloaded the videos. But the links on the Blackboard site, you can always go back and look at those later. It's just that the longer recording or the longer video kept being interrupted with commercials. And YouTube should not do that for educational videos. So let me share my screen, and then we'll see if we can watch these videos.
In 2008, archaeologists uncovered two 9,000-year-old skeletons. There's no definitive way of knowing what killed these ancient people, but we do know their bones were infected by an all-too-familiar bacterium. The ancient Greeks knew its consumptive effects as phthisis. The Incans called it chaki-onke, and the English called it tuberculosis. Today, tuberculosis, or TB, is still one of the world's biggest infectious killers, causing more deaths than malaria or even HIV and AIDS. But what exactly is this disease, and how has this pathogen persisted for so long? Typically, TB bacteria, called Mycobacterium tuberculosis, are airborne. They travel into our airways and infect our lungs. Here, immune cells called macrophages rush to the infection site, attempting to absorb and break down the bacterial invaders. In many cases, this response is enough to remove the bacteria, but in individuals with other medical conditions, ranging from malnutrition and HIV to diabetes and pregnancy, the immune response may not be strong enough to destroy the intruder. If so, Mycobacterium tuberculosis will reproduce inside those macrophages and form colonies in the surrounding lung tissue. As they infect more cells, the bacteria employ cell-degrading enzymes that destroy the infected tissue, triggering chest pain and causing patients to cough up blood. The damage to the lungs leads to oxygen deprivation. This begins a flood of hormonal changes, including a decrease in appetite and iron production. From here, microbes can spread to the skeletal system, causing back pain and difficulty moving, to the kidneys and intestines, causing abdominal pain, and to the brain, causing headaches and even impaired consciousness. These symptoms produce the classic image of TB: weight loss, a hacking bloody cough, and ashen skin. This ghostly appearance earned TB the title of the White Plague in Victorian-era England. During this period, tuberculosis was considered a romantic disease because it tended to affect poverty-stricken artists and poets, those with weaker immune systems. TB's outward symptoms even helped fuel the popular myth of vampirism. In spite of, or perhaps because of, these less-than-scientific concerns, this period also marked the first strides toward curing TB. In 1882, the German physician Robert Koch identified the disease's bacterial origins. 13 years later, physicist Wilhelm Röntgen discovered the X-ray, enabling physicians to diagnose and track its progression through the body. These techniques allowed researchers to develop reliable and effective vaccines, first for smallpox and again in 1921, when scientists developed the BCG vaccine to battle TB. These developments laid the groundwork for the modern field of antibiotics, currently home to our most effective TB treatments. But antibiotics fail to address a major diagnostic complication. About 90% of people infected with TB don't show any symptoms. In these latent infections, the TB bacteria may be dormant, only activating when someone's immune system is too weak to mount a defense. This makes TB much harder to diagnose, and even when properly identified, traditional treatments can take up to 9 months, requiring multiple drugs and a high potential for side effects. This discourages people from finishing the full course, and partial treatment enables bacteria to develop resistance to these drugs. Today, the disease is still prevalent in 30 countries, most of which face other health crises that exacerbate TB and trigger latent cases. Worse still, accessing treatment can be difficult in many of these countries, and the stigma towards TB can discourage people from getting the help they need. Health experts agree we need to develop better diagnostics, faster-acting antibiotics, and more effective vaccines. Researchers have already developed a urine test that yields results in 12 hours, as well as a new oral treatment that could cut treatment time by 75%. Hopefully, with advancements like these, we'll finally be able to make TB exclusively a thing of the past. How do vaccines work, and how do they help eradicate diseases? Check out.
That's a separate video. So did we all return? Roxy, are you now able to hear? How about you, Clarice? Can you hear now?
Yeah, I can hear now.
Okay. Maybe Roxy can't. Well, we have another video. It is longer that we're going to watch, and it goes into more detail about TB, some of the manifestations of the disease, and just a lot more detail about it. So,
tuberculosis is a serious bacterial infection caused by a group of bacteria known as Mycobacterium tuberculosis complex. It is characterized by the presence of a chronic granulomatous inflammatory reaction. In about 99% of the cases, the causative organism is Mycobacterium tuberculosis. Mycobacterium bovis is known to cause oropharyngeal and intestinal tuberculosis, but it is rarely seen now. So, in this video, I'm going to discuss about Mycobacterium tuberculosis, risk factors for tuberculosis, its pathogenesis and different types of tuberculosis, clinical presentation or signs and symptoms, diagnosis, and finally, the treatment and various preventive methods for tuberculosis. Mycobacterium tuberculosis is a rod-shaped, obligate aerobic intracellular pathogen. In contrast to other bacteria, Mycobacterium tuberculosis grows very slowly. The cell wall contains a high lipid content, especially mycolic acid. Due to the high lipid content, they do not stain with Gram stain. Here is a diagram of the cell wall of Mycobacterium tuberculosis. You can see the high content of mycolic acid, and they contain mannose-capped glycolipids, which enable them to bind the macrophages. Mycobacterium tuberculosis has the ability to survive and multiply inside the macrophages by avoiding lysosomal killing. It is the major virulence factor of the organism. Mycobacterium tuberculosis is known as an acid and alcohol fast bacillus because it does not decolorize with acid or alcohol when stained with Ziehl-Neelsen stain. Human is the natural reservoir. The infection is primarily transmitted via aerosol transmission, and they are sensitive to heat, ultraviolet light, and chemical substances like alcohol, formaldehyde, and glutaraldehyde. The bacterium primarily infects the lungs. However, it can cause disease in any other organ in the body, including liver, intestine, kidney, bone, brain, skin, eye, etc. HIV infection is a serious risk factor for tuberculosis because of the pathogenesis of tuberculosis depends upon the host immune response. Other risk factors include alcoholism, immunosuppressive therapy, such as treatment with corticosteroids, diabetes mellitus, and recent surgery. In addition, workers in healthcare facilities, such as doctors, nurses, laboratory workers, are also at risk of developing tuberculosis. Now let's discuss about the pathogenesis and different types of tuberculosis. Based on the pathogenesis of the disease, there are two types. Primary tuberculosis occurs in non-sensitized hosts, or tuberculosis which occurs in a person who has no previous exposure to the organism. Secondary tuberculosis occurs in sensitized hosts. or tuberculosis, which occurs in a person who is previously exposed to the organism. The spectrum of disease is based on the immune response of the host. In active TB, the bacilli are multiplying inside the host, and they have the ability to cause disease. If the multiplying bacilli affect only the lungs, it is known as pulmonary tuberculosis. If the multiplying bacilli affect the organs other than lungs, it is known as extrapulmonary tuberculosis. In miliary TB, the bacilli spread via lymphatics and bloodstream to the other organs and cause formation of lesions which appear like millet seeds. Miliary TB is different from extrapulmonary TB. Its infectivity is extremely high with high bacillary load, and it can be fatal if left untreated. Latent TB is caused by reactivation of dormant bacilli when the host immunity drops, and during the dormant period, the person is asymptomatic. First, let's discuss about primary pulmonary tuberculosis, which occurs in a non-sensitized person. After inhalation of Mycobacterium tuberculosis, the bacilli reach the lungs and get lodged in the upper part of the lower lobe or lower part of the upper lobe subpleurally. Then the bacilli are recognized and engulfed by the alveolar macrophages. In contrast to other organisms, Mycobacterium tuberculosis has the ability to survive inside the macrophages by avoiding lysosomal killing. While surviving, they multiply within the macrophages during the first 3 weeks of infection. Then the bacilli spread to the other parts of the body via lymphatics and bloodstream. At this point, most of the people are asymptomatic, or they have a mild flu-like illness. Due to the macrophage response, an inflammatory reaction occurs in the lungs. The lesion caused by the inflammation is known as Gons focus. The center of the Gons focus undergoes caseous necrosis with time. As the bacilli are taken into the lymph nodes, inflammation occurs at the lymph node as well. Gons focus and this inflammatory reaction involving the lymph node are collectively known as Gons complex. This is a gross image of a lung with Gons complex. After bacilli reach the lymph node, the macrophage processes mycobacterial antigens and present them to the T lymphocytes. This usually occurs after about 3 weeks from the initial infection. So as a result, T cells become T helper cells, and they secrete interferon gamma and interleukin 2. Interferon gamma causes activation of macrophage, and interleukin 2 activates other lymphocytes to become T helper cells. Activated macrophage has 2 functions. One is to kill the bacilli by various mechanisms, and the other one is to secrete cytokines such as tumor necrosis factor. In order to kill the bacilli, they secrete reactive oxygen species, reactive nitrogen species, and proteases. These substances kill most of the bacilli, but some may remain dormant for several years. They can cause latent infections when the host immunity drops. Tumor necrosis factor induces recruitment of macrophages, macrophage activation, and differentiation of macrophages into epithelioid cells. This will cause formation of granulomas ultimately. This is an image from Robin's textbook of pathology, showing the function of an activated macrophage. This diagram shows the structure of a granuloma. The center of the granuloma undergoes caseous necrosis. There can be many cell types in a granuloma. Epithelioid cells, which are derived from the macrophages. Langhans type giant cells, which is formed by the fusion of several epithelioid cells. In addition, lymphocytes and fibroblasts can also be seen around a granuloma. I have done a separate video on granulomatous inflammation. If you are interested, go and watch that video as well. It will give a lot of information on a granuloma. Now let's see what would be the possible outcomes of primary pulmonary tuberculosis. In immunocompetent hosts, the infection will be controlled by the cell-mediated immunity. The granuloma heals by fibrosis, and ultimately it undergoes dystrophic calcification and ossification. However, even if the infection is contained, some bacilli may remain dormant and cause latent infections. In immunocompromised patients, failure to control the infection causes progression of primary tuberculosis into progressive primary tuberculosis. Progressive primary TB most often resembles an acute bacterial pneumonia. Pleural effusions and lung collapse can occur in progressive primary TB. Cavitation is rare compared to secondary tuberculosis. Lower and middle lobe consolidation can be identified in a chest X-ray. In addition to progressive primary TB, in immunocompromised hosts, the bacilli can disseminate via lymphatics and bloodstream to the other organs. This may lead to the development of miliary TB, TB meningitis, TB lymphadenitis, TB spine, or Pott's disease, or TB in any other organ. Now let's discuss about secondary pulmonary tuberculosis, which occurs in a previously sensitized person. Secondary TB may arise shortly after primary TB, but more commonly occurs decades later the primary infection. This can occur due to reinfection by the re-entry of Mycobacterium tuberculosis, or reactivation of the dormant bacilli. In contrast to primary TB, the lesion involves the apex of the upper lobe of one or both lungs. Due to the existing hypersensitivity, there is a marked tissue response can be seen. Because of this, the involvement of regional lymph nodes is less prominent as secondary tuberculosis. The lesion may heal by fibrosis spontaneously, or, if the patient is severely immunocompromised, treatment is required. Untreated secondary TB can progress into progressive secondary TB. This causes erosion of the bronchial wall and leakage of content into the airways. This is called cavitation. And cavitation is prominent in secondary tuberculosis than primary tuberculosis. And this may result in dissemination of bacilli through airways. So, the bacilli can spread to the other lobes of the lungs as well. And they can reach the trachea, larynx, and may reach the oral cavity when coughing. If the bacilli containing sputum gets swallowed, the person can develop intestinal tuberculosis. Local spread of bacilli to the pleura may cause pleural effusions. Spread of bacilli via lymphatics may cause miliary pulmonary tuberculosis. Dissemination of bacilli through the bloodstream may result in systemic miliary tuberculosis and tuberculosis of isolated organs. This image shows an apical lesion with cavitation in secondary TB. Miliary TB has gained its name due to the characteristic appearance of its lesions, like millet seeds. These images show the lesions in miliary pulmonary tuberculosis. A person can develop miliary pulmonary tuberculosis when the bacilli draining through the lymphatics reach the venous blood and re-enter the lung tissue. Systemic miliary TB can occur when the bacilli disseminate via arterial blood and reach the organs like liver, spleen, meninges, bone marrow, kidney, adrenals, etc. If left untreated, miliary TB can be extremely fatal. And miliary TB has a high infectivity due to the high bacillary load. Extrapulmonary tuberculosis is referred to as tuberculosis occurs in any other organ other than lungs. It can involve several organs at once, or it can occur in an isolated organ. TB lymphadenitis is the commonest form of extrapulmonary tuberculosis. In addition, TB meningitis, Pott's disease or TB spine, renal tuberculosis, and intestinal TB are some other types of extrapulmonary TB. Now let's come to the clinical presentation of tuberculosis. Persisting chronic cough is the predominant symptom in tuberculosis. It can be a dry or productive cough, and they have a remittent low-grade fever, which appears in late afternoon and fades out by night. The patient develops anorexia due to the inhibitory action of the cytokines on the hypothalamus, and long-term anorexia causes loss of weight. Patient experiences heavy sweating during night. With progressive pulmonary involvement, the amount of sputum increases. First, it has a mucoid appearance, and with time it gets a purulent appearance. Hemoptysis, or coughing out blood, indicates severe disease. And some people experience a pleuritic type of chest pain. This is due to the extension of the infection to the pleural surfaces. Here is an image which recalls the clinical presentation of tuberculosis. Diagnosis of TB is primarily based on the history, signs and symptoms and radiographic findings. Ask the patient about the contact history and physical status before the commencement of cough. Recommend a chest X-ray to reveal white-colored consolidation on the lungs. This is an X-ray of a healthy lung. These are X-ray images of 3 tuberculosis patients. See the white-colored consolidations in the lungs. Ultimately, tubercle bacilli must be identified. Sputum direct smear for acid-fast bacilli is one method. If the bacilli present in the sputum, they are stained in bright red color with Ziehl-Neelsen stain. For an accurate result, 3 samples of sputum are required. Early morning sample is the best sample because it contains a large amount of bacilli. This is the most commonly used method. However, it cannot differentiate between species and cannot.
So what's the primary stain for the acid-fast stain? Who remembers the primary stain?
It's the fuchsia one.
All right, the carbofuchsia or carbofuchsin. And so the bacteria, not really bright red, but more of a fuchsia color, a reddish purple or purplish red color, or hot pink, really bright, intense. And then the counter stain was what? What was the counter stain for the acid-fast stain? Your hint is in the image.
Is it the methylene blue?
Methylene blue, right? So everything that's non-acid fast is blue. Only Mycobacterium is acid fast positive. So if you were looking at this slide and it's a sputum smear, that's proof of a Mycobacterium infection. Yes, you can't really differentiate the species just looking at a stained slide, but if it's in the lungs, it's most likely going to be Mycobacterium tuberculosis. And of course, you can't test for antibiotic sensitivity this way.
Do antibiotic sensitivity test. Mycobacterial culture is the most sensitive method of diagnosis. Need only one sputum sample and the species can be identified. However, culture takes about 4 to 12 weeks to give results as Mycobacterium tuberculosis grows very slowly. PCR can give rapid results and can detect antibiotic-resistant genes as well. MAN2 test is a screening method of tuberculosis. It can detect the active disease or previous exposure to the Mycobacterium tuberculosis. A purified protein derivative is injected intradermally. This is made up of mycobacterial antigens. A cell-mediated type 4 hypersensitivity reaction occurs if the person has previously been exposed to mycobacterial antigens.
So if you've ever had a TB test, sometimes they can inject with a syringe, or they just have the little device that's got 4 little pricks on it, right? They prick it into you. And remember, you would come back in a couple days, 2 or 3 days, to get the reading. And that's because it's a type 4 hypersensitivity reaction. Remember, type 4s are cell-mediated, and so they're delayed. And so what they're looking for are T cells to see whether or not they reacted, to the Mycobacterium antigens. If you did get a positive skin test, then you automatically get a chest x-ray, so they can determine if you have an active case. Maybe you did have a TB once, but it's healed over, so you see the calcifications in the lungs, or maybe your lungs will be perfectly clear because you were vaccinated with the BCG vaccine as a child, so that's why you test positive.
After 48 to 72 hours, the diameter of the induration is measured. Cut-off value of the diameter varies in different countries. Finally, let's come to the treatment and prevention. The standard treatment for pulmonary tuberculosis is 6-month treatment with 4 antibiotics. The use of anti-tuberculous drugs is highly supervised due to the increasing antibiotic resistance of Mycobacterium tuberculosis. The 4 antibiotics are isoniazid, rifampicin, pyrazinamide, and ethambutol.
So we talked about the isoniazid, rifampin or rifamycin as it's sometimes called, and the ethambutol. And with the isoniazid and ethambutol, in particular, they're targeting mycolic acid synthesis, right? Because this Mycobacterium cell wall is comprised of a lot of mycolic acid. So we use those drugs in particular to help to target it. But notice that 4 drugs are being used to treat TB. And it's at least 6 months, if not longer. But notice that it's highly supervised use. And so here's the problem, is that in this country in particular, a lot of the people infected with TB are low-income people. And they may have other issues they're dealing with, like alcoholism or drug abuse. And so you cannot simply give them a 6 to 9 month supply of antibiotics and expect them to take them, because that's not going to happen. You know, people tend to stop taking antibiotics. If you do have a substance abuse problem, you're very likely to sell the antibiotics to get money to buy the drugs that you want to use. And so what they have done, especially in, you know, urban areas and the inner cities and things like that, is they have a healthcare worker go out, find these people infected with TB, hand them the antibiotics to take that day, watch them take them, and then they return, right, the next day or whenever the next dosage is. And they do this for 6 to 9 months. So that's very labor intensive. It's very expensive, right, to pay all these people to go out and watch people swallow their antibiotics. But it's necessary because, like I said, you can't simply give these people a 6 to 9 month supply of antibiotics and expect them to take them. So, you know, it's, the cost is relative, right? It does cost a lot of money to treat these people, but if you don't treat them, what's going to happen, right? Their TB is going to spread to other people. They're going to get sicker and sicker and require hospitalization, which costs even more money. So we do need to monitor, you know, TB patients to make sure they're taking their meds. And this can be very expensive. But the alternative is a much bigger problem with tuberculosis in the population.
Isolation of infected people is essential in preventing tuberculosis. Contact tracing and screening in healthy population can be done. Early detection and treatment is important. A vaccine is available to prevent tuberculosis. It is the BCG vaccine. It is a live attenuated vaccine, which consists of Bacillus calmette-guerin, a reduced virulence type of Mycobacterium bovis. It is given at birth to prevent disseminated types of tuberculosis, such as miliary TB and TB meningitis, but it has no impact on community spread. And it does not prevent the child from developing latent and secondary tuberculosis later in life.
So any questions or comments?
Yeah, I have a question.
Uh-huh.
How long does it take after a person like contracts it for it to show up on an X-ray? Like how soon can they detect it?
Well, if it's gone dormant, then they may not be able to detect it at all unless they give you a skin test and see a reaction. So, you know, how long it takes to heal, it depends on the individual. It could be months, you know, before it heals. If you have an active TB infection, you're going to have a lot of other symptoms like coughing and coughing up blood and things like that. So then they would do a chest x-ray and see if your lungs were cloudy.
Oh, I see.
Yeah. And so, you know, what they would normally do if you think that you got exposed is they would then start, you know, giving you a TB test to see if you have any immune response to TB. And that would demonstrate that you've been exposed and possibly infected and you have an immune response. But as we saw with the BCG vaccine, its main benefit is to protect children from dying from TB, not necessarily stopping them from getting infected, but helping to keep them alive if they do get infected. And it's really not a great vaccine, but it currently is the only one available. It is widely used in many countries, but you do test positive on a skin test And therefore, if you're going into any kind of job like healthcare, you must get a chest x-ray, right, to make sure you don't have active TB. Any other questions and comments? Okay, then we'll start lab about 10 after 1.